want to talk a bit at the beginning about just some of the issues related to performance measurement in nursing, and then talk about this HOBIC, Health Outcomes for Better Information and Care, as an example, pretty big example, actually, that we've been doing in Ontario for quite a while now, and just talk about how the implications and the objectives of HOBIC in terms of bringing quality, more quality, to the information that nurses have to work with, and hence the care that they're able to deliver. The current situation in nursing, and it's a very cursory look at it, is that increasingly we've got research evidence on interventions that are effective. We've never known as much as we do now about what works and what doesn't work, and what works in terms of those patient outcomes. We've got best practice guidelines. I come from the mother lode of best practice guidelines, a huge initiative that the RNAO has undertaken, and having, I think, it just affecting across Canada and in a lot of places around the world. About what we should be doing, doesn't incorporate a lot about outcomes. That's the next phase. There's research underway evaluating the effect of bringing those guidelines to patient care. It's going on in a number of different places. In patient outcomes, the interest in patient outcomes is really being driven a lot by the safety initiatives and the priority that's being given to safety, and the quality improvement initiatives that are going on. So we're seeing a lot of interest. But, on the ground, I'm not sure we're seeing that much difference at the coalface and where nurses practice. And this is my acknowledgement that this is in Quebec. This Nightingale, 150 years ago, said, and in attempting to arrive at the truth, I think she's looking for evidence. I've applied everywhere for information, but in scarcely an instance have I been able to obtain hospital records fit for any purpose of comparison. You could say the same thing now. We haven't really moved. When it comes to nursing, we're able, because of CAI databases, we're able to talk about procedures that are being done, lengths of stay, all of that kind of stuff. But we can't tell you when a patient leaves hospital what the effect of the nursing care they've received has on that patient's status. So there are at least 4 developments that we need. We need the identification of evidence-based outcomes and nursing-sensitive evidence-based outcomes. We're also moving now into this interdisciplinary world where we're interested in patient outcomes that reflect the care patients receive from the team. Out of that, you can find a piece that nursing has. So I think the outcomes are increasingly more about the interdisciplinary effect, but nursing's making a contribution there. We desperately need standardization in nursing. We need standardization of patient assessments. I do not know why every hospital has to have its own admission assessment. Why we don't have a Canadian nursing assessment when patients are admitted to acute care hospitals and home care, etc. It doesn't really differ a whole lot whether they're going to into a hospital in Vancouver or Toronto or in St. John's. We need metrics. Nurses, we are very much a narrative discipline. That's our tradition. It's been important, but we're now moving into the metric age, and the electronic health record demands that we move to measures of what we do, not just descriptions. The descriptions can augment the measure, but we need metrics. And we need accountability. We need to be held accountable for the status the patient is in after they've received nursing care from us. Now, this is from yesterday's Globe and Mail, the Andre Picard's column, which he called Healthcare Disease. And he says, this is the quote, "It's very few physicians have actual goals and fewer still are accountable for specific outcomes. We pay them to care, which more often than not means to carry out specific acts as they see fit." Now, Andre was talking about physicians, but frankly, you put nursing and nurses in there, and that same quote holds. That's where we're at now. We really are not individually as nurses held accountable, and largely as a group of nurses delivering care, not held accountable for the effect of that care on the patient. Way back in 1999, Jennings, Staggers, and Brosh, in an article that was in the Journal of Nursing Scholarship, categorized different kinds of outcomes. And for their patient-oriented outcomes, they really talked about two subsets. One was the disease-specific, and that's really diagnosis-specific or condition-specific, largely in the physiology area, and important. And then holistic patient responses. And that's how well the patient is, and I like the phrase they use, is living with his or her problems. And for these, you have to move much more into social science and use social science measurement, and we need psychometrically sound instruments here. And so it was really the holistic patient responses that we followed when it came to HOBIC. And this was, we started implementing in Ontario in 2006, really goes back to 1999. It was a Ministry of Health and Long-Term Care initiative that came out of the nursing report that Elizabeth Whitmer, who was the minister who's just resigned from Kitchener, that Michael Rackless was talking about. We hate to see her resign. As nurses, we hate to see her resign because she was very nursing sensitive. But she commissioned a review of nursing because of just the damage that had been done in the 90s to nursing because of all the cuts and the reorganization, the reform/deform of nursing. And out of that came a recommendation that the system needed to know what nurses' contribution to patient care was. We had no evidence of that. And so we needed patient outcomes collected in data sets. And I was asked if I would lead this group. I have to tell you, I didn't know what we were getting into. We didn't know much about patient outcomes. But in fact, we assembled a terrific expert panel that took us a good 2 years to decide what patient outcomes, using the information, the framework that were available to us then. We made a decision we were going to do that, nursing-sensitive patient outcomes. So we commissioned a critical appraisal, and Diane Doran, a professor at the University of Toronto, put together an excellent team. And from the framework we provided, identified where there was evidence, sufficient evidence that we could be confident that nursing made a difference to these. There's a small suite. I'll show you those in a minute. I have to say, I always think Peggy Lee should be singing in the background, "Is That All There Is?" Because it is quite a small suite, but that's more to do with the research that's available than it is to do with the effect of nursing. We just haven't got the research yet, and all of that intervention research that's going on will pay off by giving us the evidence of other areas, other things that we do that make a difference. That these outcomes, this is what we were asked to do, needed to be span acute care, long-term care, home care, and chronic care, complex continuum care is in Ontario, that we needed to use psychometrically sound scales. We made a decision, we weren't told to do this, but we made a decision that we were only going to do this electronically. We were not going to reinforce this paper-bound system that we have. That has been the right decision and probably the thing that's caused us most difficulty, because we do not have across the system yet electronically clinical documentation for nursing. It's the worst in the teaching hospitals. There are only 3 teaching hospitals in Ontario. We have a lot of teaching hospitals. There are only 3 of them where they have electronic clinical documentation. St. Mike's, Mount Sinai, and McMaster. Others are coming along, but that's all we have. By doing it electronically, it allowed us to be able to provide information to nurses in real time. They could access a database anytime and look at what the patient's status is on admission. And it also allowed us to simultaneously create a database, a de-identified database, so researchers could go in, begin to look at nurses' contribution across the system. These databases are at ISIS and available to researchers with an appointment at ISIS, but those data are now being made available to the nursing research units at McMaster and at the University of Toronto. So that widens out the access of researchers coming from anywhere, really. Right now, we are implemented in 62 acute care, chronic care hospitals, 122 long-term care homes, and 4 home care agencies, but they're the big agencies. And believe it or not, these big agencies, several of them for-profit, got together and agreed upon what was a standardized nursing admission to all of their agencies. And so when it comes to putting that information electronically, that is leaps ahead. And so within a year, we will have home care information across all of the local health integration networks. The 4, in Ontario, you're not allowed to talk about regions. It's a bad word. So we have the local LINs. Purpose of HOBOC is to standardize assessment, documentation, and collection of clinical outcomes that are reflective of nursing practice. First major objective is to contribute to nurses' ability to plan and then assess the effects of the nursing care that's being delivered. And then to demonstrate, because it's on a database, to be able to demonstrate what nurses' contribution to client care is, but also to provide information to nurse managers about the quality of care on their units, where there are strengths, where they're not doing a good job in terms of pain management, etc., and to inform chief nursing executives, because the information is collected on a unit-by-unit basis, so they can look at how well each unit is doing relative to others across, and to bring that information to their boards. And then to develop, second major is to develop a database for research purposes. These are the outcomes: functional status, continence, 4 symptoms: pain, both intensity and frequency, fatigue, nausea, dyspnea, therapeutic self-care. I'm going to come back to that. Pressure, ulcers, and falls. Fundamental nursing stuff. There's nothing that you wouldn't expect. Therapeutic self-care really should be called preparation for discharge. It is now a 8-item scale. It's what started at 12. It's a Doran and Sedani scale. It's the only one available. We've got lots of self-care, but it's all health promotion stuff, except for this therapeutic self-care, which is, does the patient know what's wrong with them? Do they know what medications they're on, how to take them, what to look for, what treatments they're on, how to do them, what resources they need, how to get help? And these are assessed on admission to provide guidance for what nurses need to be doing across the patient's hospitalizations or care. It's only done for patients who are in acute care and home care. Again, I think should profoundly influence what we do. And nurses do these assessments on admission and discharge. That's a mountain to climb to get nurses to do, first of all, standardized assessments, but particularly on discharge, because we don't have a tradition of doing that. We've not assessed patients clinically and documented that on discharge. Benefits, the benefits are what the intentions were, that it really allows nurses, it provides information to nurses and to nurse managers to allow them to compare individual patients with others, groups of patients, to begin to benchmark, to begin to set targets for where patients need to be when they're of this diagnosis, this age, this gender, and see how they're reaching those. We've just, in March, every acute care hospital in Ontario received a 6-page report documenting how they stood relative to their comparative hospital group, and where they were in terms of both their mean and the standard deviations around that, and what their percent completions are on admission and discharge assessments. This is the kind of information a nurse manager can have. This, for example, in pain, where you set what your baseline is, and then month to month, you can ask the HOBIC report to tell you what the mean discharge is, mean differences between admission and discharge month by month, and whether or not you're getting better in terms of managing patients' pain. Same with continence, but you can do that kind of thing with all of the, I'm pointing here at the screen as if that's going to be helpful to you. But it's this information that allows you to make comparisons. The research is now going on. Quite a number of researchers are doing this, just a little bit of information. Walter Wojas from ISIS has demonstrated that patients with higher dyspnea, less well-managed dyspnea on discharge, in fact, have a much higher probability of being readmitted within 30 days. Makes sense? If you can't breathe, you're coming back. And the higher the self-care scores are, that is, you really do understand how to look after yourself, lower readmission rates. Leanne Jeffs on the St. Mike's database, both dyspnea and fatigue on admission are predictive of length of stay and alternate level of care designation. So it gives us that, begins to tell us kind of thing. Huge challenges for nurses. Not only learning how to do this, but learning how to use information. You know, we think we live in an information-rich environment, but in fact, there's very little of this kind of information available to nurses, to nurse managers. We didn't realize that we not only had to teach how to, it's KT, it's simply KT, it's how to teach how to do it, but then what to do, how to use this information, what it tells you, how you can negotiate with physios based on your ADL admissions around, okay, for every patient who is a mean of 3 or 3.5 on admission, it's going to get referred to a physio, if that mean ADL, because they need that kind of assessment. Use the information to plan your care. It's not any better for nurse managers, and it's not any better for nurse executives. It is a learning curve for all of us. Learning all of these things. And then ensuring discharge outcomes. And again, for some acute care hospitals, 30% completion on discharge. For small hospitals, 100%. It's amazing what small hospitals are doing in using this information for their discharge planning, working with physicians, sending it home with the patients, telling them to bring it to their first visit with their family physician, what their status is on this, and writing on it, please review this with the patient because she doesn't understand it. So it's really become a means for them to do that transition from home, hospital to home. HOBIC status. HOBIC is becoming national. CNA has endorsed it as the terminology for documenting professional nursing practice in Canada, and the CHOBIC has been funded now by Canada Infoway. It was the first nursing initiative funded by Canada Infoway. It's in the ICMP. CHOBIC is in the ICMP catalog, and it is a Canada-approved standard. Therefore, it's stable, and therefore it can be used in the electronic health record, and it's going to be part of the National Nursing Report Card. Norma Lang back in '99 made that wonderful thing. If you cannot name it, you can't control it, practice it, research it, teach it, finance it, or put it into public policy. But I say if we don't know what outcomes we're seeking, and we cannot measure it, and we cannot know if we have done what we have done has made a difference. Thank you.